is the key. All right. We're live. Hi, Dr. Rob Kiltz today with Dr. Tro Kalayjian, a internist specializing in health and wellness, obesity, and much more. But I'm going to let you share a little bit about who you are, Dr. Tro. Is that what you like to be? Is that okay?
Yeah, you know, it's funny, in residency, the nurses would call me Dr. Kalayjian, then it got Dr. K, and I would tell them, just call me Tro. Like none of this formality, it's just not needed, right? Like, for me at least, like, I get it. I went to medical school, you want to respect me, but just call me Tro. And then, you know, what stuck was they said, okay, Dr. Tro, okay, Dr. Tro. So ever since residency, it's been Dr. Tro, but Tro's fine.
Yeah, and I used to go by Dr. Rob or Dr. K. And now we have another Dr. K in our practice, Dr. Connor, we call him K2. And so it's all fun and interesting. And tell us about your where do you live? Where do you practice? How did you get into what you're doing? About your training, your elevator life story in about whatever time it takes.
Yeah, I mean, okay, let's go way back. I come from a household of obesity. I grew up obese. And I remember being, I don't know, somewhere between 8 and 13 years old and thinking about writing a book about weight loss called Beat the Gene, because I wanted to figure out how to conquer this, right? I knew at a young age I was going to be a doctor. I knew that I wanted to go into medicine. I saw my parents struggle, went to Weight Watchers with mom, you know, all of it, right? Whole family basically ravaged by diabetes. Hardworking, very smart family, grew up in the New York City area. You know, my parents came here with nothing and built themselves up, and they built me and my family up, and my brothers up. But we all had this weight baggage, right? And we couldn't figure it out, right? So yeah, went to, you know, tried to do, you know, vegan as a young kid, tried to do plant-based as a young kid, calorie counting, you know, you name it, running. And I had like bits of reprieve from obesity, but it just would come back, right? I mean, like, and by the time I was in medical school, I was 350 pounds. I literally helped set up the gym at my medical school, right? They were like, we got funding for a gym. Who wants to be a part of planning it? I was like, me. I want to set up a wellness center. This is my kitchen, right? And they let me set up the gym there. I have a picture with my cap and gown lifting weights but I was 350 pounds, right? And then I went to residency, you know, internal medicine, trained. I was in Yale internal medicine program, and I was 350 pounds. And when I had patients that were also struggling with weight, I would say, look, we all have to figure this out. We got to do something about this. You need to do something. I know, you know, it looks hypocritical, but we need to do something. And it was a lot of lip service, you know. I wish I could have helped them, but I didn't know how, right? And we didn't exactly get training on making behavior change stick. We didn't get training on nutrition. In fact, a calorie was a calorie, and you know, and you have to count your calories. And that was the approach, and you send them to the nutritionist. So things changed when my wife was pregnant with her third kid, and she knows how to play me. She's an attorney, and, you know, she's a brilliant lady, and you know, she knows how to manipulate me, I should say, really, above all things, you know.
Manage.
Yeah. Yeah. So she goes like, you're a smart guy. You scored on the 90th percentile on your board exam. You're a chief resident, Yale internal medicine program, you know, blah, 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 all these things. And she's like, why don't you figure out weight? Like, she was like, if this was, you know, a new diabetes drug, you would know the ins and outs, how it, you know, how it relates to other drugs. And you should be able to figure out diet and weight loss the same way. And so she really pushed me to figure this out. And so I went to the books. And went back to the books. This is like 7 years ago, and started reading. I read 3 obesity textbooks. I want to say at least 2,000 primary research articles, you know, and everything they told us was just nonsense. Basically
So
that's
the
realization.
scientific journals may not be leading us in the right direction. Is that what you're saying?
No, it's that the journals give you the answers, right? We have interventional trials literally saying what we need. If you pay any attention to the meta-analysis that equivocate diets in the literature, you can see the bias. It's just right there. It's it's staring right at you. You read the author, you see where they got funding, and then you look wait a second, I have a rule of thumb. If you're a person analyzing a trial, a meta-analysis, this is my rule of thumb. If they're comparing low carb to low fat and there's no difference in blood sugar, they're not really comparing anything, right? So it's things like this where you can understand that when they compare interventional trials to each other, they take one group, put them in a low fat group, and another group, put them in a low carb group. The low carb group always did better every single time. It wasn't a big amount. I mean, maybe 5 pounds, let's say, but it wasn't a big amount, but it was always better. If that was a drug for fertility and you always got, 5% more, what would you do? You'd go with that drug if you needed a drug, right?
Even 5% is an addition of some success, wouldn't you say?
Bingo, exactly. So I was like, wait a second. If this always does better, right? And all the direct head-to-head trials, it always does better. Why have I been doing the other thing? Why did I think the calorie counting and low fat? Why did I even ever consider that? And then you go deeper and deeper into the literature. You have to eat breakfast, you have to eat multiple small meals, and the house of cards starts to unravel, and you see that maybe we didn't get it as right as we thought. So that's that. So I lost 150 pounds in a 3-year period. I got obesity medicine certified, and I continue to devote my life to health and weight loss and making behavior change possible. I've published 4 studies, one on ketogenic diet and binge eating, another study on ketogenic diet and hypertriglyceridemia, another study on low carb diets and improvements in blood sugar without any weight loss. Right. And then, people coming off insulin in our practice, we published their data. And then I just published a very controversial paper. It's the most cited paper in American Society of Nutrition on cholesterol. So on how we can predict as clinicians when cholesterol will rise and who will experience the biggest rises in cholesterol when they go on a low carb diet. So I've devoted the last, my essentially life, but particularly the last, 7 years, 8 years specifically to diabetes, weight loss, metabolism, metabolic health, and here I am.
Tell me a little bit about how you succeeded in your weight loss journey and how other diseases might have been affecting you, and you saw the difference.
Yeah, so I was 350 pounds, and it's tough for people for doctors to understand what it's like at that weight. You're imagine, the best way I could say this, is imagine you kept getting flat tires, right? Imagine you kept getting flat tires and everybody around you said it's your fault because you're a terrible driver, right? And each time you called AAA, they said, fill in more air than you let out, right? And that was the response you got. And they said, listen, you just got to get better at driving, stop going through potholes, right? That's the equivalent, and on top of that, people make you feel bad. Look, you got another flat tire. Maybe you should stop driving, maybe you got a flat tire because you're depressed and you really just want to hit those potholes, right? So this analogy is kind of what I use to tell people what it's like to be in the mind of somebody who's struggled with weight for a long time, right? So if you're, I started with, I'm highly educated, I have motivation, I have the means, it's an unfair for me, right? I had the will and the drive to educate myself and undo all the lies that are kind of propagated. And in medicine, I quickly realized that the people coming to my practice. So what did I do? I went low carb, right? That's it. Really simple. Stuck to
And what is that low carb to you? A little bit more sort of
yeah, no problem. So
sampling of what you consider low carb, and that's would be
yeah,
helpful.
yeah. So again, everybody is different, right? So I had pre-diabetes, I had high triglycerides, family history of diabetes. So my low carb was very aggressive. It was basically as low as I could get, right? And still be
What
happy,
what
right?
did you
So,
eat?
so
What
I
what
would
was
eat,
your
yeah, meat, fish, chicken, eggs, Greek yogurt, green leafy vegetables, some berries if I, wanted a sweet kind of fruit. Um, in the beginning, you have to understand, I was coming off of processed food addiction, really, I'd say, right? So I was like a big chocolate binger. So I would have low carb chocolate. I couldn't, go without having ice cream. So I needed, kind of an ice cream replacement. I would use, like whey protein and ice and kind of like a milkshake, right? Instead of having, some ice cream. So I had to struggle with processed food addiction, all throughout that time. So I had to transition off these things. So I did my
Mhm.
best, right? I wasn't perfect in the beginning, but I did my best. So I tell people, imagine you're doing, you have, let's say protein bars, for example, if you use that as a metric of how my diet progressed. In the first year, I probably had a box of protein bars a month. And then in the second year, I probably had a box, every 2 or 3 months. And then in the third year, I was like, why am I eating this crap? Right. And I would just stick to real food as much as I can. So, and I lost, 80 pounds the first year. And the second year, I lost another, 50 or so pounds. In the third year, I lost another 20 pounds. And, certainly the real benefit of low carb is decreased hunger. So implementing intermittent fasting along the way was very critical to me. If I'm not hungry, don't eat. Right? I mean, that was as simple as that. And there was a lot of ups and downs. It wasn't
Mhm.
simple. I shouldn't say that. There were some struggles. There was how to navigate, holidays, how to navigate, restaurants, all the stuff I had to figure out. But that's the general gist of it.
And how do you tell me how you approach this in your day-to-day practice and sharing with a client who's coming in again, either it's weight loss or even those with diabetes and other diseases that don't require weight loss. What's your sort of actions for a patient that comes in with these problems?
Yeah, I mean, this is 99% of our, patients come to us for weight loss or diabetes, right? That's not, so this is our bread and butter. We have a really different approach than most clinics. We have an app that delivers basically education, a community, a support group, weekly meetings, right? We really try to bring people together outside of their homes. Remember, there's a lot of shame, a lot of guilt, a lot of feeling alone. You don't know where to turn. You don't know where to get information from, right? So we try to create social bonds, right, amongst our patients. And so we create we have an app where people can interact with each other, share their successes, share their struggles. And in that app is, lessons on everything that I've learned in a easy, kind of a highly edited way. You read an article, you watch a video, and you kind of learn. You can comment about it, you can talk about it on topics from weight loss to diabetes to cholesterol to mental health, etc. And then our clinic, we're big believers in, asynchronous care. That's the fancy way of saying, if you're taking data at home, I want it, right? So meaning like we have remote blood pressure cuffs, remote scales, remote continuous glucose monitors that are monitoring blood sugar in real time. We have ketone meters that remotely just connect automatically to our office. It doesn't need any interaction. You get on the scale, we get the info. You check your blood sugar, we get the info. You check your, you know, ketone level, we get the info, and this way, without any interaction, we can care for you, guide you, and monitor you just completely remotely without any effort, right? And things that you're already doing. And so now we can be a support system effortlessly,
So
right?
constant
Yeah.
feedback and positive feedback. And I'm assuming that goes right into the patient's records. They have access to that information. You mentioned lessons on the app. Can you give us an example of one of the lessons that we can learn from you?
Yeah. So, I mean, basically what I do is try to make the data very accessible. Everything is cited. So if you're a science geek like me, and I make a claim and you're like, hey, I want to see where that claim came from, everything is right there. You click on it, you go to the paper, you can read it. So I don't expect people to believe me. I wouldn't believe me, right? We talked a little bit about that before we started, right? We get a lot of criticism for doing what we do. So yeah, basically it's like a video. And one of the things that I'm big on is this myth of calories, right? And I'm going to just quickly say how the calorie myth can easily just fall apart. It's comparing pizza to eggs. This is like the easiest, you ask somebody, how many slices of pizza does it take for you to get full? And they say 2, maybe 3, maybe 4. I have some people that could eat a whole pie, right? But let's say the average person says 2 or 3. Okay, that's 800 to 1,200 calories, right? When I ask people how many eggs is reasonable to you, they say 2 or 3. Well, I'm like, okay, well, let's just think about that. That's like 1/3 of a slice of pizza, right? It's like 1/2 of a slice of pizza worth of energy. So if we equate energy, if we equate calories, can you eat like, I don't know, 16 eggs, right? Is that possible for you? And they're like, that's impossible. I would never be able to eat 16 eggs. I've never done that. I wouldn't be able to do that. Well, that's the same amount of calories as pizza. Well, what happens after you eat the pizza? 3 hours later, you're eating the cold pizza and you're hungry. Like the cold pizza tastes better, right? For some reason, you're like, well, how did this happen that this food is tasting better cold now, right? And I just simple question, 3 hours after eating that pizza, are you eating cold eggs thinking, wow, this tastes great, this tastes better, right? So this is the myth of calories, right? It sounds great, sounds attractive. Just, put more air in your tire than you let out when you get a flat, but it doesn't work, right? It's not quantifying what it takes, right? The hunger you feel, what it would take to maintain those calories, right? It doesn't quantify any of that, right? So this myth of calories, I think, has been one of the biggest blunders in public health in I don't know how long. I mean, I think it was so terrible to focus on calories as a public health message, right? It would be the equivalent of everybody's got a flat tire and we're telling them to put more air than they let out, right? It was wrong. And I think, that's the basis of where things start. Okay, if that's wrong, well, what's right? Right.
And tell me a little bit about where you focus, how you focus on motion and exercise and sharing those kind of ideas with the patients, and what type of effects do you see in that?
Yeah, so I'm going to tell you, full stop, exercise is a mental health, a metabolic health tool, full stop. It is not a weight loss tool. It is an ineffective weight loss tool. So if you're doing exercise for weight loss, don't expect to get great results. If you want to exercise for general health, cardiovascular health, your bones, how you feel, your mental health, right? No brainer, lay up, go for it. When your body feels good, start to move, right? When your body feels good, start to move. The problem is, okay, when you're 350 pounds, right? And hello, I was 350 pounds, and you get on airplanes and they tell you bring out the hog strap and you can't fit into carnival rides and it hurts to be, it hurts to walk, right? Should you really be focusing on movement? Maybe not, right? Maybe you need to do something to get a little bit of weight get a little weight off before you start moving your body. So exercise is a metabolic tool, right? As a tool, if you think about it, right? When you fast, you're depleting your liver glycogen, right? This is the metabolic effect. You're focusing your body, you're forcing the body to deplete what the liver's got and burn fat for fuel, right? Exercise is depleting the muscle glycogen, right? And it's a completely different metabolic tool, and it's completely different, and it has its own unique benefits. It affects mental health, bone health, cardiovascular health, but first get diet in order, then focus on movement, or at least start in a way that respects your body and how you feel. Sorry.
Today we're talking with Dr. Tro Kalayjian. Hello to Sarah, Alan, Alexandra. Grateful to have you on. And Dr. Tro is sharing his methods and ideas of anti-diabetic and anti-obesity treatments. And please, if you have questions, please share them. Thanks for joining us today. How can people find you? And then I'm going to follow up with a question.
Yeah, I mean, I'm like, best thing is the app. So we have a free app. Part of it is free. If you're looking for a community, just download the Dr. Tro app. If you need if you want to engage in social media, it's at Dr. Tro spelled out, everywhere. If you want to reach my clinic, we're a text-enabled clinic. You can literally go to our website and start chatting with our clinic right away, and it's real people. It's not like you're not reaching some. It's funny, I called the practice like a GI doc, and I swear to God, I got some venture capital firm took over the GI clinic, and I got a call center in the Philippines to try to the same number. Like, I'm not kidding. Like, so you're not getting some call center, you're getting our staff, right? And every person in our staff is basically inspired by diet and nutrition. We have Amy Igus, who's one of my health coaches. She's lost 150 pounds. Sorry, 220 pounds. I take that off. She's kept it off for a number of years now, maybe 6 years, 5 or 6 years. Brian Wiley's kept off 100 pounds. Who was another certified health coach for over 15 years. We have a mental health counselor to be. My medical assistants are amazing. One of them just got accepted to medical school. My office manager is in nursing school. I mean, this is a team like basically dedicated to, doing, basically being excellent at weight loss. I mean, we just like, I don't need, we were talking about, seeking fame and, money and stuff like that. We had just briefly talked about that. I don't need, like, God is good, man. God is good. I'm lucky.
Number one is God.
I am lucky where I don't need to worry about I just want to help you. I'm after results. I mean, I've published my data. I have a sense of pride now. I want to do great work. So, we try to cultivate a vision, a long-term vision. So yeah, you can reach out to our clinic. You can reach out to our, any social media place, but like, I'm booked out for months. So, I can't see everybody. I'd love to train doctors. That's my next step. But some of this you can't train,
But it sounds like you're sharing it and on the internet and just like we're talking here today, we focus not on weight loss. We focus on health and wellness in the mind, seeing yourself as a beautiful person, no matter the size, shape, age, or weight. And simply by going keto, carnivore, one meal a day, somewhere in there, we've seen amazing changes for everyone. And so inspiring them, I see that's kind of the major focus. One of our those watching today or listening, Michelle asked you, do you take care of patients, people remotely in your interactions? Or do they have
we're 99% remote. I'm licensed in 45 states. We have states. We had people flying to our office. I'm sure you've had this, right? We've had people fly to come see us, and I said, this is not acceptable. I had somebody literally their partner gave blood so that they can afford a flight to come. I think they just donated either. And I was like, this is unacceptable, right? So about 5 years ago, we started remote care, not with the idea of we didn't even know the pandemic was going to happen, but our purpose was, we need to make this easy for people. People with obesity, diabetes, they don't want to come into the clinic, be put on a scale. They don't want to get dolled up, drive an hour, fly in to see me. It doesn't make sense. So, you know, the whole reason like this, come to my office and let me check your blood pressure, is so the doctor can make some money, pharmaceutical companies can make some money. It's not needed, right? Just stay home, right? We can care for you at home. So we have scales, blood pressure cuffs, continuous glucose monitors, breath ketone meters, like finger prick ketone meters, but all seamlessly, asynchronously coming into our practice. We're basically monitor it completely without your involvement. And we get to deliver a higher quality of care. Why wouldn't we want that data? Right?
Well, you're in my living room. We're all, the amazing part about social media, and I'm sure you're seeing it. We've been doing it now. I mean, COVID it really was supercharging it, but for 10 years we've been doing some of it. But it's like, well, why wouldn't we just do this? Why not? And again, people know you from all over the country and likely the world also, in sharing inspirational stories. And I think that's so important. Let's see, Maxie's World question is, what you do when you go for a social event and food is the focus of the interaction? Avoid going to an event or being a person table not eating? What are your thoughts on that question?
That's an easy one, right? So here's the thing. If your doctor or your nutritionist or your personal trainer tells you to eat less and does not, what's the side effect of eating less? What's the side effect?
You want to eat more.
Yeah, you get hungry, right? So what do you do when you prescribe a medication or use a supplement, right? Let's say you say, hey, listen, I want to give you some magnesium, right? What do you tell them? You may get some diarrhea, right? You may get some diarrhea. You tell them the side effect, right? So if we're going to tell people, hey, we want you to eat less, I'm not saying that, but I'm just saying, let's say we've said that, and I don't prepare them for hunger and managing cravings, right? I have not done my job, right? I'm doing a crappy job. So managing people's cravings at social scenarios, this is a key thing. Every diet will need you to be able to figure out what to do, right? Every lifestyle will need you to come up with a strategy to deal with, your grandma saying, don't you want to have a piece of apple pie? Your friends saying, just try a little bit. Your colleagues at work saying, why aren't you eating, right? So if a doctor or your team can't help you manage hunger, cravings, and your appetite, right, and manage these situations, they've done you a disservice. So let's answer the question, okay? There's like 3 basic strategies, okay? You can eat before you go, and then you're not hungry, right? It's super easy. Eat some ribeye before you go, and then you tell them, like, I can't eat, like I'm full, and you can pick and choose what you eat then without the battle of hunger. Right? So just eat before you go is like the easiest hack you've ever experienced. It makes your lifestyle super, super easy, right? Just eat before you go. Okay. Then I have BYORE. Okay. That's bring your own ribeye, right? So bring your own ribeye is another strategy. If it's somewhere where you have a little control, maybe it's a family gathering and you're going to your vegan uncle's house or whatever it is, bring your own food that works for you. Right? I have some of my patients put me onto this thing. I'm sure you've heard of it. It's called purse bacon. I didn't know it was a thing. Have you heard of purse bacon? Purse bacon is a thing. Yeah. So people like put a Ziploc of bacon in their purse and, whatever. Maybe it's beef jerky or turkey jerky or something like that, right? It's like just something that works for them. If they get really hungry, they got something that works for them. So they're anticipating that hunger and they're figuring out a solution that works for them. But eating before you go or bringing food that works for them. The biggest problem for most people is dessert. Usually when you go out to eat, it's not, or you go to a restaurant or you go, to a holiday gathering, it's not the main meal. You have a big protein at the meal. You have vegetables at the meal. You can always eat those. You get 2 portions of those. Get the meatball appetizer. Order wings, if you're at the restaurant, right? So you have things that you can do, get the meatball appetizer, ask for 2 portions of steak or whatever protein you want. Those are all things you could do, but usually the worst is dessert, right? And so I tell people, when you're doing these social gatherings or social scenarios, just plan for dessert. Maybe bring a plate of berries with you, or just see if there's a dessert option that works for you. Did that answer it? Who asked that?
I think that answered it. And what are your thoughts? There was one other person here, and I know I always say dessert first. I mean, I'm a dessert guy, and but I eat ribeye every day, and I think the key here is bring your dish to pass at those parties, which is what you're going to eat. I always say there's always the vegans at the table, and there's the everything's at the table, but why don't you become the carnivore at the table? And I always say I only eat vegetarians or vegans. Tell me if you work with those that are suffering from PCOS and infertility or other infertility things. What's your
So we get referrals from the fertility clinics basically every day, right? This is our big. We have women who basically have metabolic issues, high insulin, high triglycerides, little high testosterone, and they want to get pregnant, and the fertility docs say, we know this guy, Tro, go see him, he's the best in the area. So we get all the fertility docs who send the patients to us. And so I don't deal with the fertility issues. We prescribed hormones, for example, in like postmenopausal women or hypotestosteronism. So that's the extent of, hormonal treatment that we'll do. So mainly fertility, we're kind of just dealing with the metabolics of it, if that makes sense.
Which of course it does, because to me, the healthy lifestyle and diet that we've been taught is actually the cause of all disease. And so what you're teaching is, hey guys, keto or it sounds similar in all of this. What's your thoughts on carnivore? And I personally recommend carnivore 1 meal a day. That's like the very best thing, in my opinion, to ER. But what's your thoughts on those sort of things?
Yeah, I think it really it depends on what you're dealing with. I've seen 1 meal a day. I've seen some people get lose a lot of weight quickly. A little bit of hair thinning, and so it depends on who you are and how rigid you are. I think most of the time we're advocating for something called 1.5 meal a day, which is, look, some days you're going to eat 2 meals just because you're triggered to eat, or you have a social scenario, and most days your hunger is going to be so suppressed, you're going to be able to eat 1 meal and it's going to be effortless, right? So we like to build in a little bit of that flexibility. And then I think the one issue, and now I'm very supportive of carnivore. I'm very supportive of very low carbohydrate diets. I think there's like 3 scenarios where I take a little bit of caution in this community, which is 1, pregnancy, 2, lactation, where we become a little bit more tolerant of carbs. If you've looked into the lactation literature, you'll see case reports. It's very few, but it's just something to be aware of ketoacidosis. I'm sure you've talked about this before in lactating women. It's like there's 20 cases in the literature, right? So when we have somebody who's going through the metabolic stress of lactating, for example, we'll kind of lighten up on the carb restriction. And the other thing is we've also seen, and I'm sure you see this all the time, if they're very strict, we love OMAD. We love OMAD, by the way. We love low carb. We love carnivore. But we've seen some very strict, kind of rigid carnivore patients on carnivore and very low carbohydrate approaches where that folate level will drop, right? So I'm sure, you're probably the expert on folate and MTHFR, and I'm sure I'm like preaching the choir right now. These are all things like we track very, very closely. So, am I supportive of it? We love 1.5 MAD, OMAD. We love it. We love carnivore, low carb approaches. But there's always this nuance, right? You know, and I'm sure you've talked about those
Yeah.
nuances, you know.
Well, the one thing I always focus on, we're meant to eat the fat, and we're meant to eat the bone marrow. We're meant to eat the organ meats, and real carnivore is all of that. And if you do that, you will be the healthiest you can ever be. If you look at polar bears and bears and many other carnivores, like a wolf and a lion, that's what we are. And so, again, it's such a hard thing for all of us. And whales, once they deliver, they often do not eat for months. They lactate. So we still are skewed with the fear of no carbs. And what I've learned in this, and as we're approaching this and having the conversation of which is the right way, and this, we're all unique and different, and yet we're not. And yet we're not, and that's amazing. Heather had a question here.
Let's flip it around, though. Let's flip it around, right? There's really no need for processed carbohydrates. Like, I think that's
for any carb.
Right. Yeah, exactly. There's very, very low need, depending on, I mean, there's some minor like instances where if somebody's very underweight and basically not metabolic, if you have symptomatic hypoglycemia, you can always find an instance, but there's no need for processed carbs and sugar. Zero.
Absolutely. Well, the problem is lean meats are deadly. Well, a rabbit diet is deadly. Lean meat diet is deadly. When we say low carb, I say fatty meat. This is where carnivore comes in, because we're so fat fearful. People think that eating fat is deadly. We use intralipids, which is a plant-based oil, to suppress inflammation. But eating fat is the key to inflammatory reduction, because soap is made out of fat. And the glycocalyx of the GI tract is supported by eating fat. So that's, again, it's such a struggle for all of us in this world of what is the right thing and finding it, right? I mean, what's the right thing? What are your thoughts on those that have had gastric bypass? Oh, what's your opinion about gastric bypass? And if you've had one, do you have a special diet?
Yeah, so we have probably the biggest rate of referrals in the area for people who are coming to us for weight gain after bypass. Look, I think the best way to kind of show the futility of that, you have to acknowledge, in a world with addictive food, with hyperpalatable food, constantly available, normalized, food addiction is normalized, right? Is a barbaric procedure potentially helpful? Yes, full stop. There are some people's lives who I can save with that surgery, right? But let's examine the root cause, right? There's a problem and there's a solution, right? So by focusing on the solution, we're kind of ignoring the problem, right? So I think if you focus on the problem, it's probably, you'll be better off, right? So is bypass and gastric sleeves and gastric balloons, are they potentially helpful for weight loss and for diabetes? Yeah, they can help, right? They can help. So we have to acknowledge that. And can everybody, address cravings on par with an addiction, right? In this modern world, with mental health issues, with lack of social support, with lack of resources and time, right? And is there a patient that may benefit from a procedure like that? Yeah, but look, I see them every day. Doc, I've gained all the weight back after my bypass, right? It is 5 years later. It is 10 years later, right? And if you understand the problem, right, which is basically an inability to manage appetite, cravings, hunger in a way that sustains health and weight loss, that's the problem. If you understand that the brain will find a way around your restriction, right? If you don't acknowledge power, right? So the people who come to me after bypass, right, and their stomach is like, basically the size of a pea, well, what do? They drink more alcohol. They can get pleasure in a way through liquid form, right? They have more ice cream. They have more nut butters. They have milkshakes. They have, really creamy and soft foods. So they imposed a restriction, and they find themselves gaining weight. And the mind is an amazing thing. It will
Isn't it?
find a way around the rules you put on it, right? And that's the same is true for keto and carnivore and any diet. If you have that diet mentality and you don't respect how the brain will adapt to the rules you put in its place. So yes, we see them all the time. Are we supportive? Less than 10% of our patients ever get referred. Maybe even less than 5%. Right? Okay. And in fact, we get the failures. We're the people that the bariatric surgeons say, well, we got nothing left for you. Go see Dr. Tro. We're those people. Right. So, I don't know how to say this. And I think you understand my dilemma where you see the utility and you're almost embarrassed as a profession that we need that. Right.
It's true. And I've always said the challenge with those that get obese easily have the best genetics ever created.
Yep. Bingo. Yep.
And so the challenge here is we in the medical profession and just in general, we chastise those that are obese rather than recognizing genetically they're actually been given the best gift ever in the universe.
Yeah, you know what? What would gestational diabetes be called in the Ice Age during a famine?
A survival.
Yeah,
you survived.
Yeah,
right?
Exactly. Yes, absolutely. Right.
And so
absolutely.
What was our natural nutritional food solution 50,000, 100,000, 500,000 years ago?
Absolutely. Yeah, exactly. Yeah.
What was it?
Species appropriate food, which is, meat and plants. Right.
Well, although how much plants did we have access to between December and March?
Yeah. No,
we didn't.
Yeah.
We were hunters, and like lions and wolves, we hunted and packed, and we learned how to make weapons. We almost never ate plants, seeds and nuts. You couldn't get, plus seed and nuts, oils and antigens and sugar are deadly for us. I mean, peanuts kill more people in the world than anyone you know. And so when we recognize the nutritional solution for humans is carnivore. And lions, there's never a fat lion or there's never a fat carnivore. And carnivores don't eat 3 to 6 meals a day.
Yeah, I think lions eat on average 1 to 2 meals a week, if I'm not.
That's it.
Yeah. So if I'm not.
But I would say in our environment of food, that's why I do one meal. Now, I love ice cream and I love French fries dipped in sour cream. But that's a small part of what I eat from time to time. 99% of the time, it's ribeye steak with foie gras and liver and salt. And I tell people, take the fat and pour it back on the steak and eat the fat, because you and I are all afraid of fat. But you said it, that you were the survivalist. You were the reason for reproduction 50, 100, 500,000 years ago. And so how do you teach people about, in this modern marketing world of you should eat this and you should eat this and you should eat this? How do you teach them? Well, maybe not.
Yeah. So one, I think that with a profound sense of empathy, right? So there's different shades of diet when you go from, going from modern processed food and brainwashed kind of nutritional strategy to, 1 meal a day, all real foods, right? Including organ meat. So I had COVID a couple weeks back. My whole family got COVID. It was my second time, and I had bone marrow soup, right? That's something culturally appropriate that I do. I made some bone marrow soup, and that's what bone broth, basically. My wife calls it sticky soup, right? And do I eat that all the time? No. But have I learned to eat that? Man, it is a superfood for me now. Um, do I, eat organs every day? No, I don't. But culturally, Armenians, what do? They eat raw liver. Raw liver is like a delicacy, right? Now, how do you get people from McDonald's, Happy Meals, right, and Sam Adams to what you're talking about? And how do you convince them that they're like, hey, look, I mean, that's a fearful topic in and of itself, right? Imagine if I told people, it's funny, I get people in my office and I talk to them about diet and I tell them there will be a time soon, right, where you will eat one meal a day and you won't be hungry, right? You will not be hungry. You'll be able to eat one meal and you'll be surprised, right? And what happens is they're like, there's no way, right? There's no way. And what happens every single time? They get to 8 weeks and they're like, holy crap, you were right. I thought you were crazy, right? I thought there was, and
you are crazy,
right? And we published this. You know why we published this? Because people need to know. People like you and me need to know. It's like the next generation of doctors. We have to train. We talked about this training. The doctors have to know. We published that binge eating symptoms resolve, right? Okay, we showed this in a case series, right? So those symptoms are, how does that happen? We can get into the science of it, right? So we showed that it resolved. So the idea here is it's a tough sell. And we have to recognize with empathy that some people just aren't ready to stop eating pizza, right? And we need to be able to meet them where they are and kind of walk them through. Like I said, when I first started, I was eating a box a week of Quest bars. I don't remember the last Quest bar I ate. I got no stock in Quest, right? but I recognize its value. Let me tell you, if somebody has an issue with chips, cookies, pasta, pizza right now, I can get you low carb in under a week, right? And enjoy all those foods. Now, is it an ideal? No, but it's kind of like, it's an acceptable alternative, in my opinion, on the way to an ideal, and it makes it easy for people, right? Most people can't go from, eating junk food, compulsively to, I'm going to eat raw liver.
But the terms we've created, see, I think saying something is a healthy lifestyle is automatically a label that we should eliminate in medicine. So the labels we give things create the thing: healthy lifestyle, healthy diet, which are lies, in my opinion, in all of this. Because if you're living a healthy lifestyle, we see so much disease from a healthy lifestyle. Something must be wrong in our label, and that's the biggest problem. Tiffany asked about, she struggles with IBS for many years, lots of medicines. She recently started a heavy meat similar to keto, but not fully. Kiltz is keto. The past has been able to manage my IBS and decrease symptoms. What's your thoughts on how a keto significantly reduced her IBS and Crohn's symptoms?
Yeah, I mean, one of my co-authors in our recent paper on cholesterol, he basically reverses ulcerative colitis. We've had many patients tell us going carnivore, doing elimination diet, they experience an improvement in IBS. I think the current approach in medicine to medically unexplained symptoms, which is what I would describe as IBS, is a medically unexplained symptom, is, try this antidepressant or try more fiber. There's like kind of BS approaches, right? So I think we really need to embrace the use of nutritional strategies to these medically unexplained symptoms. We know in the literature, for example, right now, okay, that there are some people, if they failed fiber in the past, let's say they have chronic constipation, right? And they failed fiber and they failed, kind of the supplement use, right? That, in fact, fiber elimination in this select set of patients improves their outcomes, right? So if the standard advice isn't working for you, right, we need to evangelize patients to keep going, right? To find a new approach, to try something new, to try a new strategy. And I think nutritional approaches and elimination diets have definitely a role there. When you have a medically unexplained symptom, the doctor really hasn't given you a good reason for what you got, and you've tried the standard approach. Well, let's empower those people to try nutritional strategies. I think an elimination diet has some use there, and we've seen it. We have interventional trials showing that, like chronic pain, low carb versus low fat. Low carb actually improves chronic pain. It improves knee osteoarthritis. It improves mental health outcomes. Virta just published 2-year data of patients on a low-carb diet. They had a 20% reduction in their depression symptoms, right? So seizures, right? We know that ketogenic diets prevent seizures. So, these things, right, that we often cannot explain, and we use medications to treat. There are some times under the care of a doctor, I think it's very reasonable to try these, elimination diets or nutritional strategies. I can tell you, I've seen the other end where people come to me and say, Tro, my psoriasis went away. I went carnivore. Well, we actually do some testing. We found out they had celiac, right? So you unravel. And I tell you, there's countless patients. I tell people, if you're trying an autoimmune protocol or an elimination diet, like it's a low risk, if it's monitored, it's low risk, but don't always expect a reward. I've had people try to reverse autoimmune disease, and so just have a good doctor, somebody you could talk to and figure out if it's working or if it's not working.
If it's unexplainable and idiopathic, it's because doctors are blind to the idea that carnivore, one meal a day, and keto is a high fat diet, actually, and a paleo is a high fat diet. And that's kind of been our challenge, I think, in this world of nutrition, is really the definition, although ketone bodies, I think, are just kind of there anyway. But, it is mentioned. Now, you mentioned about epilepsy and how this has been used for so long. One of the challenges I see in medicine is somehow we want a study to explain everything, rather than looking back at your grandmother and the fact that she gave you chicken soup and you felt better. And we just can't recognize that it's already in front of us. What's your thoughts?
I'm like I don't know. I got to tell you, every ounce of me believes in contributing to the medical literature, right? So one is, if I see something that's unique, I shouldn't keep it to myself. I should write it up, right? And so that's what I've done. And so my mantra is, if the data's not there, let's put it in. And that's why the ADA right now says you have to lose weight for your blood sugar to get improved. So we published our data. I had a med student here. She just happened to see 3 patients come off insulin, which is a normal occurrence here basically every day, right? And she's like, they didn't lose any weight. Like it was very quick. It was like, yeah, we have CGMs. We do this all the time. She's like, well, you got to put this in the literature. So we wrote up this case series. We showed that basically with no weight loss, right, patients were able to come off their insulin and their blood sugars on CGMs were improved, and their A1C followed, right? Obviously, we had an average A1C of, in that study, 11.5 come down to 6.5, right? So even the most severe diabetics, wow, significantly improved without weight loss. So why did we publish this, right? Because we need the studies. We need people to know that it's not just Tro and Rob, getting together and this is, their crazy thoughts. We have to show them, hey, this is real. And we did it with binge eating. We did it with cholesterol. Right now, the NLA, the National Lipid Association, says a ketogenic diet is severe, contraindicated in high triglycerides. Well, we took people with an average triglycerides of 900 and brought them down to 200. Now, granted, this is a highly monitored setting. We ruled out kind of genetic issues that need to be considered, right? And how do we do it? With a low carbohydrate approach. So why did we publish this? Because if we don't, we're going to propagate the same nonsense, right? That recommendation from the NLA is a grade 3 recommendation based on expert opinion. So the next time they go to make their guidelines, they have to consider what I just put out.
Yes. Yes.
And they can continue to ignore it. That's fine. But now at least I did my job. You know.
Have you been? What? Tell me a little bit about how much sort of backlash you're getting from the traditional medical community or the scientific community, and how many of them are like, "Wow, this is the best things we've ever seen." And you don't have to answer this if you don't want to.
No, I'll answer it. It's like two grounds. My patients are forever grateful. I'm booked beyond belief. We have a podcast that the Low Carb MD podcast. It is been the top in medicine, in the medicine category for several years now. So you have that one side of things, right? But you have people who are tell me that I should lose my license every day, right? I've published these things in the medical literature so that they can benefit, and those same doctors will come after me and say this guy's saying that, something that's not in the guidelines. The guidelines say, the ADA right now says you have to lose weight, right? That is the way to reverse your diabetes. Well, we showed them it's not true. So my study is literally against those guidelines, not in its entirety, but in certain parts of it, right? The NLA right now says contraindicated low carb diet and severe hypertriglyceridemia. Well, our case series literally showed, right, in a peer-reviewed setting, that they're not exactly completely right. Now, there's parts of those guidelines that are great, but there's parts that need more flexibility. And our newest paper, was a doozy. We basically took a massive survey of people who had a different response, had an increase in cholesterol, and we developed a way to predict who will experience higher rise in cholesterol than others, right? And we showed that we could take people, from my clinic, 5 patients who had cholesterol and LDL in the several hundreds, and we brought it down to normal levels with no medication, right? Just understanding the science. And now, how did we do that? How did we, was it some miraculous thing? No, we gave them a potato a day and a little bit of fruit, a little bit of berries. That's how we did it, right? And we published that we were able to reduce LDL by over 200 on average, in one case by 500, right? And this is a patient who said, Tro, I don't want any medication. You're not going to convince me, right? And they had a team of cardiologists, and I told them, like, look, every doctor in the world would give you medication. And so anyway, how did we know the intervention would work? Well, because we follow the data. We look into the science, right? We this is what we do every day, right? And so we published this so every other doctor now knows. Right? We had a survey of 700 people. And how do we predict who will see a higher increase in cholesterol when they go low carb? Well, we know, okay, the lower your weight, the higher cholesterol goes. The less frequently you eat, the higher cholesterol goes. The lower your triglycerides before you started, the higher your cholesterol goes, right? And what do you do if it goes really high and if you want to do anything about it? What do you do? In that case, when you rule out genetic issues, you have a negative stress test, your coronary calcium is 0, right? You're in a monitored setting. Just bring back a little bit of carbohydrates, the number comes down, right? I mean, so why do they say that I'm crazy? I don't know. I mean, we're putting this data out there for them, and that was the most cited study in the American Society of Nutrition. And people said that I should have my license taken away. I'm not some guy in isolation. We're getting calcium scores, stress tests, genetic testing. Like, these people came to me and said, I don't want a medication. I know this is, related to my diet. I wasn't this way before. So I don't know what to tell you.
We're sharing new and different ideas that have actually been around for thousands of years. None of this is new. And that's the amazing part to the story. And it's, the more you publish and share it, and I think the most important thing what you're doing is sharing it with everyone. And that I think you have to be proud of. And the patients I'm hearing from say amazing things about what you're doing, and the podcasts that you're doing are really fantastic. So Dr. Tro Kalayjian, what is your website again that people can find you and learn more about how bariatric surgery can be eliminated by following your ideas and low to no drugs?
You say your ideas, but you, like you said, this has been out there. Atkins said it before Atkins. It was used for hundreds of years, and that was our species appropriate diet for a long time before that. I think, look, bottom line, it's the Dr. Tro app. You go to iTunes or wherever, iOS and Android. You can find me on social media, Dr. Tro, drtro.com, spelled out. But this is standing on the shoulders of giants. Why are we publishing this data? We have people like Eric Westman, David Ludwig, that are here and serving as mentors and helping to bring this stuff to the literature. People like Sarah Hallberg who've devoted their lives to exposing people to low carbohydrate approaches. Finney Volek, so many others. I can't even. Jason Fung. It's the bravery of people like Tim Noakes and Gary Fedke, who've literally been tried and exonerated for recommending low carbohydrate approaches, just to show you how vilified these approaches are. But bottom line, I'm standing on the shoulders of giants. You and I, we can't do this without them.
All of us together in this community. It's ultimately the patients, the people of the world are really the biggest shoulders, right? Because ultimately healthcare, we're all working together. They're the ones that are teaching us, because we're all writing and sharing their stories, which is really their data. We don't own any of this data. That's, I'm not saying ownership, my data. It's not our data. It's their experience. I was really excited to learn not that long ago about Dr. Salisbury. Do you know who Dr. Salisbury was?
No, tell me.
Do you know anything about Salisbury steak?
Yeah.
Okay. Dr. Salisbury was a doctor in the Civil War that fed the military men steak and coffee to eliminate all their diseases. And then he wrote about it. Okay? And so there's so much you and I don't even understand about the stories. And ultimately, it's people's stories that you write about. And the more people's stories you write about, and all of us in the family, but ultimately, we're working for people. And the more, the more we do that together, and we're going to continue to follow what you're doing, share you on our CNY Fertility, drkiltz.com, and those in our everyone out there, share more ideas and energy so Dr. Tro can share more of health and wellness. So, Dr. Tro, thank you for joining us today. Appreciate you.
This is it's been an absolute pleasure. Hopefully you can give me some tips to figure out how to get more doctors kind of, helping me. I can't do this alone anymore. That's I'm sure private practice is tough, and I'm booked and I need help. So maybe.
Well, here's what I've learned.
Yeah.
Here's what I've learned about trying to teach someone. You teach someone by example. And the more patient and persistent in the process of what you believe, even if the strongest storms work to take you down, you never, ever, ever give up. And, I have been chastised by many. I've been reported to the Office of Professional Misconduct for talking about this. I've had patients, obviously, who didn't believe it, didn't want to do it. And I always say that, and a hospital that told me that I'm a volunteer faculty on at the medical school, I can't talk about this. And so what did I get inspired to do more of? Talk about it. Yeah. Because we've been given a license to practice medicine. And our job is not our peers, it's people. And the more we focus on people individually and inspire them what you've done for yourself and the people stories, that's all that matters. I'm being sued by a practitioner for sharing a method of treatment patent for a supplement. Well, I didn't know doctors and other people patent a recipe and come after you for simply sharing it with your patients. And so what have I been inspired to do? Talk more about it. And all of us need to, I say all the people watching this, listening to this, listening to your podcast, need to recognize that this is not meant to be us against them. It's all of us are working as a family. You don't have to convince anyone. I would say your inspirational things you're doing matter most. And we're in the healthcare community to learn from others. But most of all, each individual patient, no matter what they're suffering from, the single leading cause is incorrect advice from a healthcare expert. And it starts with the wrong diet for a human. It's as simple as that. And the one thing I've stopped doing is testing and testing and testing, because testing leads to a diagnosis of a disease, which usually leads to a drug treatment or a dissection, right? But I'm inspired by you, and you got to work more on my podcast and all those sort of things. So again, Dr. Tro.
Yeah, very happy to be here.
God bless you.